Greetings, everyone, and thank you so much for investing your time with us today on Tuesday, November 23rd to discuss brain health matters and the importance of health system readiness. My name is Robin Saccone, and I'm the Manager of Access and Health Policy at Roche Diagnostics and your moderator for today. I want to acknowledge, as we gather here today, that I'm on the traditional land of the Treaty 1 territory, traditional territory of the Anishinaabe. This acknowledgement calls to us to commit to continuing to learn how to be better stewards of the land we inhabit, as well as pay respects to the spirits. I'm very honored to be here today with an esteemed panel of experts to discuss the importance of health system readiness in the context of dementia and Alzheimer's disease in Canada. For 125 years, Roche has been committed to improving lives. The long-term thinking of our founders shaped the way in which we make a difference in the lives of millions of people around the world. Our goal with dementia and AD is no different. Nearly 2 years into the COVID pandemic, the unprecedented global response offers lessons on the growing health crisis of dementia. It shows that stakeholders of different backgrounds, governments, healthcare professionals, the private sector, scientific organizations, and the public come together to mobilize and address the looming public health crisis. COVID-19 and dementia share similarities in scale and in the nature of challenge. Both diseases have a health impact that is concentrated among older adults and at-risk groups, but cause broader societal economic disruptions across families, communities, societies, workforces, and economies. Both require similar strategies for effective response. To name a few: proactive public health and prevention efforts, accessible tools for early and accurate diagnosis, health system readiness, and modernizing care. Before we go any further, a few poll questions for the audience to truly show the scale of the Canadians that suffer from dementia. So we have a live poll if you click on the live poll button, and we're going to ask everyone to read the 3 questions that are in there, to start and answer them, and then we will share the results at the end. We will take a couple of moments now. We'll end the polls. I think they're starting to slow down. Oh, there's some shifting. We'll give it 30 more seconds. Okay, and we'll end the polls. So this is great. So for the first question, B is the correct answer. And we see that 69% of our participants in the audience got the correct answer. For C, it's 10.4 billion. So we've got a tie there, which is really great to see that we have a very knowledgeable audience on dementia and Alzheimer's disease with us today. And the third one is 20.8 billion. This is awesome. We're so excited to have you here and to kind of further your discussion and your knowledge about dementia and Alzheimer's disease. So there are challenges in health system preparedness for dementia, even though this crisis has been growing for decades. To discuss this further today, we've assembled a group of nationally and internationally recognized experts in their respective fields who have a passion for clinical discovery, health system innovation, and improved care for individuals, caregivers, and families. Before we get to the presentations, here's the format to give you an idea of what you can expect for our time together today. Each of our esteemed panelists will be presenting around 15 minutes in length. At the end of all presentations, we will have 15 minutes reserved to open up questions to the audience. Feel free to submit your questions at any time during the live Q&A, and we'll do our best to get to them. I will let the audience know the comprehensive bios for each of the panelists are available on the CSPC website. I will not be going into them in detail, but I encourage you to look at all the amazing accomplishments that these individuals have. So let's get into our discussion. Our time today will be a bit of a journey. We'll be starting with the current state of AD and the Canadian healthcare system, moving towards highlighting the importance of focusing on underserved communities and remote care, then looking at the vision of the future state from a policy lens and learnings from other jurisdictions, and then the importance of transforming the AD care pathway with technology. Our goal is, whatever your role is in shifting policy, developing health system readiness, that each of you will come away today with something: a new idea, a fresh perspective, a new strategy that you can apply to helping our healthcare system get ready for individuals that will be diagnosed with AD and make it better for those already living with the disease. Laura Tamblyn-Watts is our first speaker. Laura Tamblyn-Watts is the CEO of CanAge, Canada's National Seniors Advocacy Organization. She previously served as the Chief Public Policy Officer at the Canadian Association of Retired Persons and in multiple positions at the Canadian Centre of Elder Law, including National Director. She holds multiple faculty positions, including at the Faculty of Social Work at U of T and the Institute of Life Course and Aging. Laura, over to you.
Thanks so much, Robin. Really delighted to have this opportunity to talk a little bit from the policy perspective and really trying to move the agenda forward. 2 seconds. So CanAge is Canada's National Seniors Advocacy Organization. We're not trying to sell you anything. We're a nonpartisan, not-for-profit. We try to speak as the voice of older people. We've got teams in BC, Alberta, Ontario, Quebec, Nova Scotia, and Newfoundland. And we take seriously these visions and values. I'm just going to show them for a second because it also focuses a little bit on how we're going to address the issue of AD and try to move the conversation forward. I'm also flipping up a few examples with my notable friend, Alex Mihalidis here from AgeWell. We really work collectively. And again, I'm going to just show you that because I want us to think a little bit about partnership and collectivity in moving the agenda forward. I'm going to talk in a really basic way about what, so what, and now what with regards to policy agenda, the state of where we are right now in Canada, and what is it we need to do to move it? So when I'm talking about what, I'm really talking about setting the context. We all may remember that the World Health Organization put forward not the requirement, but the strong hope that there would be a public health response to dementia by partner countries. And the action areas that you see here, 1 through 7, are the suggested framework for the WHO push to have national strategies. So that is one of the things that at that supra-governmental policy level, this is what we call, soft policy, we created this framework and really strongly suggested, and I'm using the word suggested with a question mark here, that governments move forward to create national dementia strategies. And, Canada's a good member of the global international AD community. We're a good member of the WHO. And many of you joining us today were part of this really important push to get that dementia strategy for Canada. I remember being on the stage. I didn't quite have a pair of scissors and a red ribbon in front of me to cut, but I was there with policymakers, the Minister of Health, and many of you taking pictures and celebrating what we thought was a real policy landmark, a real achievement. And it was, and it remains so. You'll see here the 5 key areas that we talked about in the National Dementia Strategy for Canada, and then the 3 national objectives. And I'm just going to flag in particular those 3: to prevent dementia, to advance therapies and find a cure, and to improve the quality of life with people living with dementia and caregivers. So this is what Canada said as part of its national dementia strategy, as part of its commitment to inclusion with the WHO. So time has passed. I want to talk a little bit about the landscape and the why now. Every one of you joining today has either been at the front lines, been running your organizations, been supporting family and friends, and or riveted to the news, particularly with the framework of thinking about the National Dementia Strategy and thinking about people with lived experience and caregivers. Overwhelmingly, folks in long-term care, about 75 to 82%, depending on which jurisdiction you live in, have some form of cognitive impairment, and overwhelmingly that is Alzheimer's dementia. We know that confinement took place in long-term care. It also took place in assisted living, supportive housing, group communities, retirement homes, seniors' lodges, and for people who were over the age of 70, confinement also at home. We know that overwhelmingly the people who have Alzheimer's dementia are still in the community at home. And it's really that comorbidity that places you with the high degree of frailty into long-term care. So when I think about the impact of COVID-19, the landscape that we're having this policy conversation in, it has fundamentally changed. How many of you were putting your head in your hands when you saw the triage policies from provinces, from the public health agencies? How many of you closed your eyes and shook your head or wept when you saw that people with dementia were at the very bottom of the list for triage? If they got COVID-19, the chances of them getting care, very small. The chances of them getting treatment in long-term care homes with things like respiratory supports, almost zero. And at the policy lens, we know that we cannot keep spending money the way we are, that we've been printing money. And so austerity is coming. And so when we're thinking about the what, we need to think about this landscape to have this conversation at this moment. We had military intervention and really bring a heartbreaking focus to some of the issues of people with cognitive impairment, food being left on the table and not being fed, people being left in feces because of their cognitive impairment. People with cognitive impairment don't complain. People with cognitive impairment were left alone. People with cognitive impairment were left to die. And it's important to see that they did die and are dying. So there is an urgency that we can think about. Today is the speech from the throne. It's a historic moment. Our first Indigenous Governor General is going to be speaking and laying out the plan of this newly elected federal government. But I don't expect any great surprises because Alzheimer's and dementia is nowhere to be found. It wasn't found in the previous mandate letters, and I don't expect to see it in the current set of mandate letters. Despite the landscape, despite the people who were left to die, despite the social isolation of people with dementia at home, despite the pleas of family caregivers for supports, I do not expect Alzheimer's and dementia to be in the mandate letters forthcoming today. That's depressing. But let's use this moment and talk a little bit about what we can do to change that. Many of you will be familiar with the Eisenhower decision matrix. What you want to do is get up to number 1, right? Things are urgent, important, but can you get them there? And I suggest to you that you don't just need to get them in that box, but you need to get them where that little letter M is. They must be both very urgent and very important. And we know that when we're talking about the so what of this, we have an opportunity. Many of you will remember Patton's Fourth Army, which was a mirage, actually. It was a strategic push to take the current situation and change it for the benefit of keeping people safe. And in some ways, I think we need a Fourth Army. What we need to do to move things to not just that urgent and important, but up into the far corner is one voice, one message, and one ask. And we do not have that. We don't have a current clear champion. The federated model of the Alzheimer's Society provides richness at the community level and connection with the issues, meaning most people in those communities, but it has its complexities. And we have a new leader of Alzheimer's Canada, and he's getting up to speed. But at this moment, we do not have any clear champion. So we don't have one voice, and we're not speaking with one voice. We don't have one message. The strategy is abstract and complex. It's a good strategy from a policy point of view, but if you get a copy of that and you're a busy minister, your eyes are just going to glaze over. And we don't have one ask. What we have is a basket of wants. We have a whole bunch of things that a whole bunch of groups want, and we know they're all really important. So I think we used to be, when we created the National Dementia Strategy in phase two, it was important, but not urgent on a policy level. And I think that we have slid to the idea of not your emergency. I think that when we talk about dementia, everyone agrees it's bad. And I'm not saying that myself. I'm just saying that if you're talking to policymakers, people will tell you about their family. They will tell you about how important it is. They will tell you about the hopes they have for a better future. But they will not move forward necessarily to do anything about it because it is abstract. So one of the things that we tried to do was create a roadmap to an age inclusive Canada to push some of these things forward. And I'm just going to share with you where some of these aspects live to push that agenda and to build more than myriad voices into one voice. So in our optimal health and wellness, you'll see that issue 7 is there. You'll see that, of course, we're thinking about all of the other issues, particularly capitalizing on the spotlight in long-term care. We've been interweaving the issues that have been in the national strategy into very specific examples. So, for instance, essential caregiver visits, talking about the fact that health and social care are both needs, that cognitive decline comes with social exclusion, that we need to make sure that we are addressing the ageist and stigmatic way that we're thinking about a disposable, and I use that term with great worry, group of people. So when we're thinking about our now what and we're moving into action, I think we want to share with you how we with vision moving forward. First, we look at it with a lens, everything that we do. And you'll see the very first thing on accessibility, neurodiversity, and cognitive impairment. That means we're bringing a lens to everything and moving to implement the National Dementia Strategy. At the World Health Organization, they created the Global Status Report on Public Health and Response, and they point out essentially that many countries who have dementia strategies are stalled. They do not have funding and investment. They created a step-by-step guide about how to move it forward, and we're in phase C. We need an operational work plan. We need to allocate the budget because what does not get measured does not get implemented. So CanAge is working with Roche and other key partners like AgeWell and the National Initiative for Care of the Elderly and the Alzheimer's Society to create impact measurement, to understand what we've done. And we are moving from need to current, particularly around one ask. So we want to move from this, which frankly looks impressive, but isn't a way that a policymaker is going to be able to make change, to this. We are asking that we allocate 1% of the health budget to Alzheimer's dementia, 1%. That number is knowable, that number is predictable, that number is replicable. So the time is now. We really hope that you can join us in. It's free to join, canage.ca/join. That means we can write to you. And of course, all of our different ways to be connected. We want to share your resources and your materials, and we want to help to bring forward that one ask. Thanks very much.
Laura, thank you so much for such a passionate presentation and taking us from the now to the so what to the now what. I'm going to welcome Dr. Megan O'Connell to the stage now. Dr. Megan O'Connell is a registered doctoral clinical psychologist and the professor of psychology at the University of Saskatchewan, and the remote specialist of primary care support for appropriate dementia care. She is a member of the Alzheimer's Society of Canada COVID Task Force and the Psychology Working Group and the Methodology Working Group in the Canadian Longitudinal Study on Aging. Dr. O'Connell will be taking us through the how to do this important work with our Indigenous community. Megan, over to you.
Wonderful. Thank you very much. And thank you for helping with the slides, Laura. Nice introduction, and I just want to emphasize that I co-lead Team 15 in the Canadian Consortium on Neurodegeneration and Aging, CCNA, but I'm also a member of Team 18, which is focused on Indigenous dementia care. So I work in both the field of rural dementia care and Indigenous dementia care. Although when I work in Indigenous dementia care, I'm an ally and a supporter as opposed to leading projects. So wonderful. So I would like us to consider some of the unique needs that rural older adults have for technology. And understanding these unique user needs is really quite fundamental to development of technology that they will attempt to use, and more importantly, that they will continue to use. And rural dwelling older adults experience disparities in access to healthcare, and these disparities can really ideally be mitigated by use of technology, and technology can really benefit rural and remote older adults. I'd say even more so than for other older adults. These are the quintessential end users for technology, rural older adults. The digital divide, so I guess I can't see, Lauren, if you're on the next slide, but I think you'll figure it out. The digital divide refers to the technology infrastructure barriers that older rural adults experience, including lack of financially accessible broadband internet access. This is a problem that impacts many rural older adults, and this digital divide has lots of consequences. They have reduced older rural adults, because of the digital divide, have reduced exposure to technology. And this creates a second digital divide. And this digital divide is one where not having exposure to technology creates a psychological barrier. And this is why a psychologist is studying this area. And we refer to this as the double digital divide. The fact that you have lack of physical infrastructure access creates the second divide, which is a psychological divide. And this one's important to understand in the context of rural older adults, because this psychological barrier will persist even if, and even when, because I do believe we will, fix the rural digital divide access barriers with new technology, like SpaceX, for instance. I have a lot of hope. But we still have the psychological digital divide. And this is referred to in the literature as the rural paradox. The fact that rural families would benefit the most from technology, or information communications technology, or ICT, and they have the least access to it. As I said, rural families are the ones who would really benefit the most from technology advancements and from adoption of technology. The rural paradox exists in rural Saskatchewan, which is an area we've studied, amongst adults age 60 plus, so older adults. You can see here that a lot of older adults reported using technology, but a substantial minority continued to report absolutely no use of technology, such as computers or the internet. And even if older adults did report using technology, many of them reported slow, intermittent, or non-high-speed internet access. And over half indicated that living in a rural and remote location impacted their technology use because they just didn't see it as reliable or easily to access. So even if they did have it, the quality was low enough that it impeded their use of it. So we made use of this information to create a new model for how we understand technology adoption. So we revised the technology acceptance model to include rural and remote dwelling as a very important demographic factor that impacts technology use. So in the TAM, or the technology acceptance model, various demographic factors impact your access barriers. Those are the physical ICT barriers. But then they also impact the psychological factors. And there are two psychological factors that matter. One of them is your psychological assessment of how easy the technology is to use, the ease of use, summarized as PEOU here on the TAM. And it even impacts your psychological assessment of the perceived usefulness of the technology. So if you don't see it as easy to use or useful, you're not going to have a good attitude toward technology, and therefore you're not going to use said technology. And this is the basic premise of the rural adaptation to the TAM. So in CCNA Team 15, which focuses on rural dementia care, we've been using technology for remote dementia care and are very sensitized to the many physical and psychological barriers to technology adoption held by rural families. An assessment of the technology readiness, support for use of technology, and continuing monitoring of use of technology in the therapy is core to our delivery of the suite of psychological interventions that we deliver remotely using technology. And some of these we have been delivering remotely for over 10 years. So technology has changed quite a bit in that time. Pre-pandemic, we were able to leverage the eHealth Saskatchewan video conferencing suites. There are over 300 in the province. And this helped us to sidestep access barriers. So even if a family has never owned technology or used technology beyond a television, they can go to their local hospital, they can see their therapist remotely using the video conferencing network. And this was a great alternative to getting around some of the access barriers that we see rural families have. In the pandemic, however, we've had to move to alternate modes for remote intervention. Many of the remote telehealth suites are connected to long-term care, which of course was restricted in access and continues to have some restrictions due to the ongoing pandemic. So now we use a variety of remote approaches. And we use a variety of remote approaches, including another new initiative for us, which was forced by the pandemic, which is the virtual rural and remote memory clinic. So in addition to the work that I do in the intervention suite and as a researcher, I'm also a diagnostician. So I work in a diagnostic clinic for dementia, and we focus on serving rural families. And we had to move the rural remote memory clinic to a virtual model because of the pandemic. And we are flexible in which approach we use. You can see here I've listed quite a few different technology-based approaches for reaching rural families. And we are part of our technology readiness assessment. We modify our approach to families. We don't make them adapt to us, and that's detailed in a Journal of Medical Internet, or JMIR, research paper here. And we do a lot of support and training for families to get onto this technology. Because as I mentioned earlier, even if you had ICT access, you didn't have the physical barriers, you might continue to have psychological barriers, such as perceived ease of use or perceived usefulness. So perceived ease of use can be mitigated by support and training, but it takes a lot of time. And we have been only able to see half of the capacity of families for this diagnostic clinic due to the staff time and training required to get people who've never used technology onto said technology. So most of the time we attend the interviews as a group, the nurse, the neurologist, and the neuropsychology team. We do the assessment with the family. And then while the patient is getting a telephone-based neuropsychological battery, which I'll talk about in a moment, we interview the caregiver alone by video conferencing. And feedback and diagnosis and management plan is communicated by video conferencing later in that same day. Remote cognitive assessment has been probably the biggest challenge for us moving on to this virtual diagnostic platform, in part because so few cognitive assessments are validated for the remote context. And in fact, that's one of the reviews that part of the Alzheimer's COVID task force did early in the pandemic. We detailed and looked at the literature to help guide clinicians on practices in the pandemic, and found that remote diagnostic assessment's really challenging, but has promise. And we, in this early paper in the pandemic, published early in the pandemic, we recommended real caution in using tests standardized cognitive tests that have not been normed or developed or validated for the remote context. And these concerns were later echoed by neuropsychology practice professional organizations. So one of the things that we are careful to do in our new virtual memory clinic is use a neuropsychological battery, albeit brief, that has normative data that I published in 2021 for this remote context, because that's pretty critical. So we can do a lot to help mitigate rural disparities in access to health. A lot of training, a lot of extra support, and real consideration of how to best change our practices. But there's another group I'd like to talk about for whom there's an additional layer or an additional barrier to access, which is a cultural barrier. So cultural context is overlaid on issues common to rural residents. So most of the time when I'm working with Indigenous families, they also are living in areas where ICT access is also a problem. So cultural context is very important to consider, although I recognize for all cultures, for Indigenous peoples, there's the cultural context that is in the overlaid or under by the history and experience of ongoing colonialism that's experienced. And we suggested that this was a triple digital divide. So it's not just the physical infrastructure barriers and the psychological infrastructure barriers, but we now have the cultural barriers, which are unique to Indigenous peoples due to the history and continuing colonialism. So co-design to create culturally safe care is really critical when working with Indigenous peoples. And this is exactly what we're doing in one intervention in the rural and remote memory clinics interventions. So how do we do this work? Particularly for me as a clinician and an ally, I'm a white settler, and I'm an uninvited guest in the territory of Treaty 6 in the homeland of the Métis. That's where my home is. So the work we do together is not merely co-design or community-based participatory work. It's deeper, and understanding cultural safety or working toward cultural safety is really the key to this work. Cultural safety and how to achieve that is a process, and it goes way beyond mere cultural competence. And whether it's achieved or not is not decided by you as the clinician or the researcher, it's decided by the person you're working with. So it makes it even harder to figure that out. So you can set the stage for cultural safety, you can facilitate cultural safety, but whether or not you've achieved it is up to the person you're working with, the Indigenous person you're working with. So we've made use of these principles in the RMCI, the Rural and Remote Memory Chronic Interventions, in developing the Indigenous Caregiver Support Group, which you can see is one of the suite of interventions. So after first being asked to do this work by a community-based researcher advisor group that serves 11 First Nations in southern Saskatchewan, I have been working to co-design a culturally safe caregiver support group for Indigenous members, or specifically various members of the First Nation communities in southern Saskatchewan. And as I said, I'm a first-generation settler and ally, and I don't have the cultural knowledge to do this myself, even if I have been working as an ally in this space for many years. So I listen more than I lead, and all decisions are collaborative, including how to structure the group, how we work together, etc. All these decisions are made by the team and not me. So we got a grant for this work, and much of the support has gone to paying for technology in MiFis. And this is because of the intersection of that lack of ICT access and the cultural context. So working in this field means you might need to supply the physical infrastructure and the training and support to have the work together. Our support group is evolving into a spiritual support group. It's led and ends with ceremony. And I see the power of this group already early in our work together. And this model really needs to be disseminated. And actually, this is a common refrain from group members, that they say this is a very helpful group, it's very needed, and they would like to see more people have access to it. So I'm sure we'll be working together for many years to make sure this happens across the country. I want to now talk a little bit about assessment in cultural safety and assessment with Indigenous peoples. And I think I may be taking a bit more time than I thought. I'm not sure how my time is. I can't tell. Even though I practiced this, it was all fine. Okay, but I'll be a bit faster. Pardon me? Okay, that's good. That's perfect. I can do that. Indigenous peoples experience higher dementia prevalence rates than non-Indigenous peoples, and they perceive dementia symptoms differently. So there are some differences when working with Indigenous peoples when doing cognitive assessments. And cognitive assessments that are commonly used really fail to account for culture properly, and that can lead to a lot of false positives. So some of the work we've done, this is a chapter that's in press, really shows that, or postulates that standardized assessment, such as what's done or is the cornerstone of clinical neuropsychology practice, is at its extreme the antithesis of cultural safety. And as you deviate from standardized practice, you deviate from using tests with established validity. So it gets really challenging to balance validity and standardized assessment with cultural safety. And I would say that really the only way to do that properly is to start from scratch and co-design a cognitive assessment tool. And that is exactly what was done with the Canadian Indigenous Cognitive Assessment Tool, or the KICA. So I'll talk briefly about that. The KICA was co-designed. The co-design process is shown here in an illustration from a publication by Jacqueline et al. The co-design process is iterative. It takes a lot of time and a lot of effort to do. And then once, of course, it's done, then you have a tool that you can begin to do the validity assessments for. But this is really the only way to do a co-design cognitive assessment tool. And on this last slide about the KICA, I present a couple of publications here, one led by Jacqueline, and then one led by Walker. And I will say notably, I'm a member of the team, but I do not lead this work. Jacqueline's paper talks about the notion and the 5-year-long iterative adaptation process that we used to take this cognitive assessment tool that was initially developed with and for Indigenous peoples in Australia and adapting it to the Canadian context, at least the context in Northern Ontario. And then subsequent work has been done by Walker to look at the validity and the psychometric properties of this newly developed tool. And I've been using the KICA in my memory clinic, pre-pandemic, of course, and have evidence on its accuracy relative to an interprofessional clinical assessment. And I can say the paper's forthcoming, but I can tell you that the tool is quite valid and probably comparable to other common screening tools, at least in my memory clinic sample, which is predominantly a majority culture sample. So if you're working with Indigenous peoples and you need to do cognitive assessment, I urge you to look up the KICA and to do work in a way that works best because it was developed with and for Indigenous peoples. And finally, I'd like to thank you for your attention. And I'd also like to thank the funders, particularly for the CCNA work, because most of this was funded by CCNA Team 15, Rural Dementia Care, and CCNA Team 18 on Indigenous Dementia Care. So thank you.
Thank you so much, Megan. You've given us a lot to think about, just highlighting the psychological barriers and how they continue to exist, and the importance of, as we ready ourselves for health system readiness, how that needs to be a key factor in our thought process as we go forward. And of course, the importance of culture, education, health, and social equality across the map. So thank you so much, Megan. And I'm going to welcome Dr. Craig Ritchie to the floor. So Dr. Ritchie is the Chair of Psychiatry of Aging at the University of Edinburgh and the Director of Brain Health Scotland. In 2015, he established the Centre for Dementia Prevention, and that year took on the academic leadership role of the EPAD program. In 2017, he was elected as chair of the Scottish Dementia Research Consortium, and in 2020 became the inaugural director of Brain Health Scotland. We're very excited to learn from you, Dr. Ritchie, today. So thank you very much for joining us, and I'll turn the floor to you.
Thank you. Thank you very much, Robin. And it really is a great honor and privilege to be here and joining you here from Scotland. So Over the next sort of 10, 15 minutes or so, I want to talk to you about a program here in Scotland, Brain Health Scotland, and which is a really great example, I think, of what we're trying to do in terms of healthcare readiness moving forward. Going to change gear a little bit because in some ways, brain health and dementia prevention are two sides of the same coin. And I think most dementia strategies do have a reference to prevention of dementia being a key target, a key objective. What we've done here in Scotland is carve out that space specifically for a brain health agenda, a brain health strategy, which we developed over the next few months. So the presentation itself, I thought it'd be worthwhile giving a little bit of, they say, optimistic scientific background to why we believe it is possible to prevent dementia by focusing our public health policy, our public health work, our policy work across the life course, really, but maybe targeting also individuals in midlife with individual risk assessment and personalized prevention plans. So that's the topic of disease before dementia. I'll then talk a little bit about how we've taken that scientific backbone and try to put it into practice. Like I said, on a public health and an individual level. And to close, I'll talk about, if not a new speciality, brain health and neurodegenerative disease, the BAND initiative. What I'd like to also do is use it as an example of a very large global initiative, which we're part of here in Scotland, called the Davos Alzheimer's Collaborative, DAC, which has a whole work package dedicated to healthcare readiness. So if we go to the next slide. Yeah. So if we turn back the clock almost well over 100 years now, the gentleman on the left is Alois Alzheimer and the person on the left is Auguste D. Alzheimer, of course, identified in Auguste D the pathological lesions shown in the next slide, which are characteristic of what became known, of course, as Alzheimer's disease. And I think one of the key things that I take away from this, and I'm not trying to bore people with a neuropathology lecture, is that Alzheimer's disease is a brain disease. Next slide. And if you think about how the disease is manifest, we have been, in a sense, unable to detect the disease in the brains of individuals because, you know, simply put, we can't do brain biopsies. We can't look directly at the pathology. So since Alzheimer's described the case of Auguste D in 1906, we've had to rely on the clinical symptoms that emerge from the disease and approximate that to what we believe is going on in the brain. Next slide. However, the dementia concept, if you like, which we've had to rely on really since the turn of the 20th century, is under a little bit of threat. And the reason for that is that since the 1990s, we've been able to detect the pathologies of Alzheimer's disease through biomarkers, particularly neuroimaging and spinal fluid assessments, and in the very near future, also blood-based biomarkers. So what that means is that, as Alzheimer's, I think, probably would have intended, we are actually able to detect the disease directly rather than indirectly through clinical symptoms. So what I often say is that we've got to remember Alzheimer's disease is a brain disease with cognitive symptoms. It's not necessarily a cognitive disorder. Next slide. And one way of thinking about this in a kind of a cartoon form is that up until very recently, we've spent a lot of our time considering and conceptualizing Alzheimer's disease only through older people who have, if you like, late stage disease, even though it may be mild cognitive impairment or early dementia. They're still probably 20, 30, 40 years even into the course of their disease. And what we're planning to do, and what we are doing now through research evidence as well as clinical practice, next slide, is shift our gaze, next slide please, shift our gaze to an earlier stage of the disease process, whereby we're more likely to be able to detect these early stages of disease and principally rely on biomarkers for that. The key for us in many ways was to take that research evidence which we've gathered from studies like Prevent Dementia and the European Prevention of Alzheimer's Dementia Programme and put it into practice clinically. So in 2018, on the basis of the research evidence that we've been gathering, I was fortunate enough to have a meeting with the First Minister here in Scotland, Nicola Sturgeon, and presented in many ways what I've just been speaking to you about now. And this was really very much geared towards saying, look, if we're able to identify and detect disease early, if we're able to maybe manage the risk factors before they develop for things like, poor cardiac health, diabetes, social isolation, the things we've learned about in the Lancet Commission report, we have every opportunity through primary and early secondary prevention to prevent dementia. Next slide. And this was our goal. That from 2020, unfortunately, there was a start of a pandemic in 2020, but from 2020 onwards, Scotland would deliver a reduction of incident rates in dementia year on year, so that we all benefit from the lowest rates in the world. And the way we were going to do this, next slide, was not just to specifically look at the individual, nor were we going to just look at public health and policy, but rather what we would do is create this ecosystem, we call it this brain health pyramid, which at the bottom would certainly be looking at how one can, through primary prevention, maybe reduce the numbers of people that exhibit or develop or manifest the risk factors for dementia. And we've got work in schools, we do with educational programs in primary schools or elementary schools and secondary schools, working more specifically with targeted populations who may be at higher risk through family history, through history of head injury, etc., with education and information sharing, increasing health literacy. And then when we get nearer the top of the pyramid, we start working now with individuals and brain health hubs and indeed in brain health clinics. And I think it's that brain health clinical work I want to share with you in a little bit more detail in the next few slides. So this is a very busy slide, and I know we'll be sharing these with everybody later. But in essence, what we have is a stepped approach, a series of triage points, where somebody can come into a community-based centre, brain health hub, as we're calling them. There'll be dozens across Scotland by 2025. And they can have what we refer to as confident conversations about brain health. On the basis of those conversations, somebody may identify themselves or be identified as maybe having symptoms or signs or risk factors of concern, which would then mean they would go and be offered an appointment with one of our nurses. Those nurses would then be working within the National Health Service and would do a series of risk factor analyses, do a blood test for amyloid status, for genetic risk, and some early cognitive testing. We'll use an algorithm, a machine learning based algorithm, to determine whether or not that individual needs any further investigation and be seen by one of the consultant physicians or psychiatrists working in the team. All this will work through to ultimately develop for that individual what we refer to as a personalized prevention plan. One of the things we keep getting asked, and in the next slide, I'll expand on this in a little bit more detail, is, well, who's in and who's out? Brain health is a very broad concept. I mean, it could incorporate any brain disease. Could that be stroke? It could be neurodegenerative. It could be multiple sclerosis. It could be a brain tumor. So we've had to sort of try and define in some ways what the population of interest is, given the primary aim is to prevent dementia. We're really trying to gear ourselves to those conditions which have a neurodegenerative etiology. What happens if you're in? What happens if you're out? Next slide. So one way we think about this is if the clinical services are implicitly geared towards preventing dementia, then the brain health focus in this regard is to detect early neurodegenerative disease. And I think also because of the role that cerebrovascular disease plays, not just in vascular dementias, but also in other types of dementia, that those would be our main focus. But if it's a neurological condition, for instance, like multiple sclerosis, where dementia is not the primary clinical outcome or concern, the debate is whether that condition is in or out. And we're going to spend some time finding out where that boundary is over the next year or two. If there's a psychiatric illness, for instance, depression, which is a risk factor for neurodegenerative disease, as well as being a manifestation, a symptom of neurodegenerative disease, then the argument that we are making is that should be in. We should manage that depression, that anxiety within a brain health service. However, if there's a psychiatric condition which is neither a risk factor nor a manifestation, for instance, schizophrenia or psychosis, then they would be out. And clearly, if through scanning and through other tests we find things like brain tumors, then they're clearly out and get referred to the appropriate services. Next slide. So this is a simple cartoon to kind of the RAG system, the red, amber, green system of what's in and what's out. On the left-hand side are the green panel of what's very much the the modus operandi of the Brain Health Service are on the red, was definitely out. Next slide. One of the other things we're often asked about is whether or not all of this testing is actually of proven value in these early stages of disease. And a lot of the work that we've done and some of the Cochrane reviews I've even published have suggested that some of these biomarkers have reasonably good sensitivity, but quite low specificity for some of the pathological lesions one sees in Alzheimer's disease. However, it may be the case that a lot of these pathological lesions we see in Alzheimer's disease, like the accumulation of amyloid and the accumulation of tau, are actually consequences of normal aging. So the older one gets, the less specificity these biomarkers may have to a disease process. So earlier in the course of disease, it may be the case that having, if you like, amyloid in your brain when you're 50 is much more pathological than having amyloid in your brain when you're 95. So I think we've got a lot to learn about this. And I think that's one of the key components of the Brain Health Services. And we'll be continually collecting data and looking at these data to see if we can improve our risk prediction models. Next slide. So I just want to finish with a very, very large international initiative that came out of the World Economic Forum about 2 or 3 years ago, which is a Davos Alzheimer's Collaborative. And there's a work package, a work stream within Davos called Healthcare Readiness. And what they're looking to do is do a series of projects that will encourage and improve, ultimately, healthcare readiness at a global level. And one of those projects, the flagship project, which we're involved with, is to look at this. I'm not sure if you can see it very clearly, but there's a little circle, little blue circle in the middle there called early detection. Next slide. And what we're going to be doing in this Davos initiative over the next year or so is next slide again, take that healthcare readiness early detection piece and really try and understand it in 6 countries or 6 regions of the world: Jamaica, Mexico, Brazil, Florida, Japan, and Scotland. And we've all got different backgrounds, we've all got different resource availabilities. And the key point is that these 6 countries or regions or states are going to learn from each other in what we call a community of practice about where the pinch points are, where the problems are, what the solutions are. And it's a very exciting initiative to be part of. And I think one of the key things that we'll be doing in Scotland, which is slightly different from the others, are twofold. Number one, we won't be doing these early detection tests in primary care. We'll be doing them with the nurse early on in our care pathway. And secondly, we're the only country, if you like, within the community of practice, which is actually trying to initiate this at a national rather than within one clinical service within the country or region. So my last slide is a summary of the presentation. I hope we've got convincing evidence that's accumulating almost on a daily basis that the diseases that lead to dementia have their origins at least in midlife and potentially even earlier. And I think it stands to reason, like any chronic disease, the earlier you can pick up the condition, the earlier you can identify the disease process, and put in place interventions, be it risk factor modification or in future pharmacological interventions, of course, combination of both, then the better the prognosis. Brain Health Scotland is really trying to take that research evidence and put it into practice. There's some risks in this. The research evidence is still accumulating. There's still some doubters. There's still some doubt. But I think, we can't wait 20, 30 years until that doubt is gone. I think we need to implement what we know already. As long as we do no harm, implement what we're doing already. And at the same time, as the bottom bullet point says, collect data as we're running these clinical services and always be learning and always be modifying through quality improvement at what we're doing. So next slide, I'll just stop there. And thank you very much for your attention. I look forward to the panel discussions later.
Thank you so much, Dr. Ritchie. That was fabulous. So, what can we learn? We can identify earlier, we can look at the risk factors, and we can take every opportunity to prevent dementia, and the importance of creating an ecosystem. And I'm going to add in that important point around continually connecting data to help us manage those risks. I think that's a really important point as we look at health system readiness and a key factor. So we'll bring you back for the panel discussion at the end, but now we're going to turn over our virtual stage to Dr. Alex Medeiros. He is the Associate Vice President for International Partnerships at the University of Toronto and the Scientific Director of AgeWell Network of the Centers of Excellence which focuses on the development of new technologies and services for older adults. Alex has been conducting research in the field of technology to support older adults for 17 years, with over 200 journal papers, conference papers, and abstract publications. Alex, I'll turn it over to you.
Great, thank you, Robin. I hope you can all hear me okay. And I think that Laura will be sharing my slides for me. Wonderful. So I'm going to try to get through my presentation quickly because unfortunately I had to try to tether through my phone data to get online here, and I just got a message from Bell that I'm reaching my maximum data before they throttle me. So let's get to it. So first of all, thank you very much for everyone for having me here. I'm going to talk a little bit about technology. We've heard already how our population is aging, that we're having more people with dementia within Canada. In fact, Canada will be considered one of the super age countries by the year of 2030. However, the feeling is, next slide there, please, Laura, that even in face of all these diseases and impairments and disabilities, whether it's dementia, whether it's Alzheimer's disease, or whether it's a motor deficit, we can all age well with the right interventions in place. And obviously the intervention I'm talking about is technology. So we've heard a lot about how technology can be used to support older people. Specifically, you can go back, please, Laura, thank you. Specifically around the use of commercially available products and off-the-shelf technologies. And we're seeing a lot more use of things such as iPads, smartphones, and other types of devices to help with social connectedness, to connect with their healthcare providers, and other resources as well. Next slide, please. Now, before I move on, though, and talk about some of the technologies that we are developing, I feel that we need to actually, break some myths about older adults and their comfort level with technology. So, AgeWell, the network that I'm scientific director of, we conducted a study with over 2,000 older people to understand their attitudes towards technology before and during COVID itself, and we found some very interesting results. Next slide there, please. And in fact, what we found, you can just hit the next button too, Laura, for the next one to come up. And actually what we found is that the myth that older people are not confident to use technology actually is not true. And this actually supports a lot of research. And you can see some key statistics here. And specifically, we saw 3/4 of those who were surveyed over the age of 50 are confident using the current technology. 2/3 of them are actually willing to pay out of pocket for the technology if it allows them to stay home at age, which is actually a surprising find that we had from the survey. And finally, with respect to COVID-19, the pandemic, 2/3 of those that we polled also found that technology can help lessen the impact on COVID-19 in their daily lives, which is a very important aspect for us to be moving forward. Next slide. So what I want to talk about, though, is some more complex technologies that we're starting to see come out in the support of older people with dementia and other types of impairments. And what this diagram shows is typically what our environments and our worlds are looking more and more like. We are now living in a connected society, and our homes and our personal environments are, no different than that. So this picture indicates how pretty much everything in our house can be connected at this point. And the interesting thing about this is not the fact that we can control our dishwasher or know when our dryer is done with our clothes, but the fact that we can collect a tremendous amount of data. And in fact, our homes and our systems that we use, whether it's a smartphone, a tablet, a smartwatch, or an appliance, is collecting a large amount of data that can really be used to understand what is going on with a person within their own homes, and more specifically to understand what is happening with an older person in their daily lives. Next slide, please. So here is an example of one technology that AgeWell has been developing within their own homes. And What you see here are 3 screenshots that were taken from a video that typically I would show that indicates how we can be collecting physiological data, for example, such as an ECG from a person. And when we work with older people with dementia, we often get questioned in terms of, well, can they have a wearable? Will they remember to put the device on? Will they understand how to collect information that's required to send to their family doctor or their healthcare team? And so what this slide indicates is how we're collecting health data now with actually nothing on the person, but in fact using furniture and common objects in your home to collect the information. And so in this particular case, here's one of my graduate students sitting on a sofa, watching television. The middle part of this slide shows how we're actually collecting a live ECG from the person. And then the final panel here shows, you can see 2 little pieces of shiny brown tape on the sofa. And it's basically, these are person even through several layers of clothing. So again, this is just an example of the kind of data that we can collect without putting any additional effort on the older person, especially in light of a cognitive impairment. And you can imagine how powerful this type of technology can be, that we can be collecting information such as ECG, heart rate, blood pressure, et cetera, from a person as they're going about their daily activities. And why this is important is because additional sensors, we can now know whether the person's heart rate has been elevated because they just climbed a set of stairs, or their heart rate or blood pressure is spiking and all they're doing is just sitting there watching television, which obviously may indicate something going on with their health. Next slide, please. Now, another interesting area of research that we're also looking at is the use of social robots to support people with dementia. And we've been looking at using robots across a variety of activities, right from supporting people with dementia during their activities of daily living. So for example, having a robot understand if the person is having trouble with a self-care activity, whether it's washing their hands, brushing their teeth, or making themselves a cup of tea or a simple sandwich. And then the robot itself actually intervening very much like a caregiver would, providing the prompts and the reminders required for the individual to get through the activity on their own. Now, what you see on this particular slide is another application of social robotics, and this is actually in performing cognitive assessments. So this is using a commonly used task where a picture is shown to people who may have dementia or suspected dementia or cognitive impairment, and they're asked just basically to describe what they see. And what would happen then is a clinician would then score the person based on their description of the picture, but also in terms of the type of language they're using and the difficulties they may have. We've done the exact same thing with this social robot, where the robot using the screen on its chest will show this picture, ask them to describe what they see, and then the robot will listen to their response. Now, the advantage of using technology to do this kind of test is we can basically make it very systematic and we can make it very consistent, obviously, across the people that we are performing the test with, because the technology itself will analyze the data always in the same way and take some of that subjectivity out of the process itself. So in this particular case, the robot would show the picture, the person would describe back to it, and then while the robot is analyzing the results, it actually then engages the person essentially basically in social chit chat. It asks the person about how their day is going. It talks about the weather, if that's what the robot knows the person likes to talk about, or sports or whatever else it may be. When the results then are provided back to the person, we are very careful to use language and saying, well, this is not a diagnosis. This is not saying that you have a cognitive impairment. But the robot basically will gently explain to the person that, we are seeing some differences in your memory, and that we may want to now connect you with your family doctor or your care team, who then would also have the same data collected by the robot, so that they can have an informed discussion with the person. Next slide. Now, all this data that we're collecting is fantastic and can be really useful to make assessments of the person right there in the present. So in terms of understanding what is going on with the person. So for example, seeing if the person is using the bathroom in a normal number of times compared to their baseline, etc. And what you see in this diagram here is actually a radial plot from 0 hours to 2400 hours. So basically the clock that shows various motion sensors in the various rooms described here on the legend of an older person's home. And this data is collected over approximately a period of 3 months. And what you can see in this data are very clear patterns of living for that individual. So you can see that they go to bed around 11 p.m., they're getting up around 7 a.m., they're doing maybe their bathroom activities, they're eating breakfast, and then they go out for a little walk, and you see a little gap here in the data points because they've left the house, and then there's a repeat of this information. So again, from this data, that if we all of a sudden see a change in this pattern, we may raise some alerts to the individual, to their caregiver, and to their care team. But what's more important with this type of data is we can actually use it to predict what may happen with the person. And in fact, that's what we've been working on within my research lab here at UT, is trying to use things such as machine learning and artificial intelligence to predict changes in a person's physical and cognitive health before it actually happens. Next slide, please, Laura. And for example, using the data set that I just showed you here, we developed models that after 3 months of data collection, we are able to predict with 90% accuracy who was going to develop dementia over the next year. And this was based on comparison with gold standard assessments that basically showed that our model was accurate and was able to make these predictions on a relatively simple data set. Because motion sensors that we use in this particular project are those that typically many people would already have in their homes if they have a home security system or something else. Next slide, please. Now, these technologies that we've developed are all great and all, but we have one big issue right now, and that is transferring these technologies actually into the hands of the people that need them. That is the older adults themselves and their caregivers and their families. Unfortunately, Canada right now, when it comes to the age tech sector, is kind of in this dry, barren part of the land here where a lot of these innovations are just sitting in the research labs still. And the problem is because Canada currently is lacking the right amount of investment and the right number of partners in order to take us across this road into this nice rosy green pasture, which represents the technologies actually being on the marketplace. And so this is one aspect that the Age Well Network is working on, and we're working with fantastic partners such as CanAge and others in order to rectify this and actually to start to bring more investment into the age tech sector in Canada, work with our policymakers to ensure that we can actually transfer these products to market, and more importantly, working with industry and other types of partners who can deliver these. Next slide, please. So one example of this is one of our largest partners within AgeWell is Best Buy. And this comes always as a surprise to people. And for those who are international, Best Buy is just one of your typical big box stores for electronics, and they'll come, set up your television, etc. But what Best Buy is doing is they're actually getting into the aging marketplace. And in the United States, in fact, Best Buy has launched their own smart home service called Best Buy, where they are now going into older people's homes, assessing their needs, and then outfitting them with the types of sensors and smart home systems that I described to you. And so Best Buy obviously is very interested in doing the same thing here in Canada and is working very closely with the AgeWell Network to do so. Next slide, please. Now, in terms of moving things forward and working with partners with Best Buy, et cetera, the big thing we now need to understand and try to look at is, well, what is now the future of caring for older people with dementia and others within their own homes using these types of technologies? And I just want to leave you with some questions as for us to think about as we move forward. Next slide, please. So the question is, is the future of the care of older people going to be completely online? And are we going to continue with the trend that we've seen during the pandemic of more people using things such as teletherapy, telerehab, telemedicine, et cetera? Next slide. Is for older people the role of robotics playing a more hands-on role as depicted in this obviously mocked up picture, but one that is depicting where robots are doing things such as transfers, helping older people with also mobility issues on and off the toilet, and other types of things that typically a family caregiver would have to do. And as we all know, many of them are not trained to do these physical activities, and therefore there is a high rate of injury among family caregivers with these types of transfers. Next one, please. Or is the future essentially that our care teams and even our family caregivers basically become data scientists, where they are receiving large amounts of data from all these different sensors. They're waiting to hear what the artificial intelligence agents are telling them to do, and then they're responding appropriately. And therefore, really having our caregivers and our care teams have to be trained as well to use these types of technologies. Next, please. And with that, I will end it there. I thank you very much for having me. I wish you all to join the AgeWell community, and the link is here. You can receive information about AgeWell from that, and also my contact information was on that final slide as well. And with that, again, thank you very much, and back to Robin.
Thank you so much, Alex. And I'm glad your bandwidth held out, because that was a really interesting presentation and taking us forward into the future. So I think we saw a commonality between Craig's presentation and yours in terms of the importance of data being a really key enabler as a predictive analytics, and the importance of bringing that forward. So I guess I'm going to welcome all the panelists back to the stage, and I'll give it a second. Excellent. Thank you all for joining me here. So I don't see that we have any questions in the live Q&A, but I do encourage our audience, if you do have a question for our panelists, to put it in, and I'm happy to read it out and ask. Of course, we've prepared a couple questions just to kind of get the discussion going. So if you, from your perspective, could give one piece of advice to policymakers on how to prepare the healthcare system for dementia and AD, what recommendation would you provide, and how would we get there? So Laura, I'm going to start with you. I'm going to go in the order of our presentations. Oh, I think she might be frozen. Laura, if you can hear us, we're unable to hear you. Okay. Thank you. Okay, Megan, I will go to you. Let's see.
Let me double check, first of all, that you can hear me.
Yes, we can hear
Okay,
you.
good.
All good.
So how can we prepare it in the future? I believe is
one
what you're
piece
asking
of advice
about.
that you would give.
Well, some of it is providing that training and support. So as I said, the rural people might be a unique population, and of course, being able to provide that training and support, and not developing technology sitting in isolation in a lab, and really co-designing that with the end users in mind. And that is really critical when you're dealing with Indigenous peoples, and having them own and the technology really done for them, with them, and them not feeling like it's being done to them, I think is pretty critical. So I think, thinking of these special populations, I recognize they're not the majority of older adults, but they really do have unique needs.
Great. Thank you, Megan. Craig, would you like to comment?
Yeah, no, I think the one advice I would have, and I have had with policymakers, is stop waiting for the research to be perfect. I think research is great. We can have a lot of fun in our ivory towers, but the reality is we want to get research into practice. And I think sometimes the level of evidence being sought by policymakers is way beyond what's ever going to be possible. And how much evidence is there that a parachute works? I mean, some of the stuff I think we're proposing is just common sense, and we should be able to do the research on it once it's actually in the real world. Alex, I loved your slide, by the way, about the barren ground with the road and the orchard on the other side, because I'm Googling it, trying to find it, because I think that's such a lovely analogy of the barren ground where research is taking place. There's a big wide road, and then there's the real world, and we have to bridge the two, bring them together 100%.
And Alex, your piece of advice, if you could give.
Yeah, I think just building on Craig and Megan's comments, we need to be prepared that, technology is here. People want technology, and this is going to only increase as our older adult demographic changes. As the baby boomers come in and becomes the older adult population, they're going to have a full expectation that they're going to be living in a connected world and especially connected health. And so we need to work with policymakers, again, to get over that road and into the nice green pasture and be ready for it as well. Because if not, we're going to be having the same conversation 5-10 years down the road from now.
I think that image has resonated with everyone, Alex. You might see it in a couple presentations circling in the next little while.
No problem. That's fantastic. That's great. So.
Well, we do have a question from the audience, and it says, thank you to all the speakers. I wonder how the pandemic changed the way older adults in rural areas use technology. Who'd like to start?
I'll take that one.
Megan? Awesome. Jump on in.
Yeah, since that's where I've been focusing. So, well, what we did see, and I think fits beautifully with the data that Alex had presented as well, is that the pandemic created new need for technology in rural settings. So people who didn't previously want or have any interest in using technology became new adopters to technology. The biggest challenge, of course, was the training piece. And we were able to leverage one of our intervention arms in CCNA, our suite of interventions, to do the training and have done that successfully and evaluated it. And we have a publication on that. So that was great. One of the other things, though, that we did was we thought, we're missing a large swathe of people in rural Saskatchewan, at least, who aren't connecting and not filling out surveys because the announcements for those are coming electronically. So what are their barriers and how can we get them on board? So we surveyed them using random sampling phone dialing and found that indeed, yes, there were quite a few people who increased use of technology in the COVID pandemic, and it was driven predominantly by that psychological perceived usefulness. But the thing that was the main barrier to those who didn't use it during the pandemic was that perceived ease of use. So really speaking to how we need to really think about training and support for people who don't have access to it. And that paper hopefully will be out soon because it's a COVID adaptation to the technology adoption model, fitting the data that we have. So I'm kind of excited about that.
We're looking forward to it. We'll make sure we can get it circulated as well so many people can read it. Alex, is there anything you from the research that you've done would like to add?
Yeah, I think, Megan is absolutely right and with her response, and the data that we also found is, again, there was an increase in use and they're not going back. It's amazing how we spent decades trying to get telehealth in the province of Ontario, and then the pandemic hits, and over a weekend all of a sudden we have telehealth. And again, people are not going, even people living in urban centers, they're not going to go back to the way it was before. And so I think this is what we need to be prepared for, but we still need to build the infrastructure and take into account all the factors that Megan described in her presentation.
Great. And Craig, is there anything you'd like to add to the discussion?
I think that was a very specific question for experts like Alec and Megan working in this space. We obviously do have some telemedicine working into remote areas of Scotland, but I think Canada and indeed Australia lead the world on this. So I think I'll defer to their answers.
Fair enough. So if we were to look at the Canadian landscape, which I think we've done nicely today in terms of our journey that we've taken us through to, what's working now, what opportunities are, what we can learn from other jurisdictions, and really what our opportunities and our barriers are. If you were to come back a year from now to this conference, what would you hope to see different if you were giving this presentation? What would you hope that Canada would have achieved in a year around brain health? If we could do one thing.
So maybe I can start.
Great, Alex.
First off, I hope this presentation will be in person next year, in a year from now. But in terms of 1 year from now, I think really recognizing obviously the role of new technologies and making that a priority. Obviously later on today, the mandate letters are coming out for our new ministers in our government. We hope that technology is in there, and more importantly, that the dementia strategy is going to have the funding that's required to implement it from all aspects. And I really hope that will be a priority of our government over the next 12 months.
Thank you. Megan?
Sure. What I'd like to see in a year is that we have a push toward getting rid of our continuing digital divide. And as I said, I'm speaking more from the rural and Indigenous lens. And the pandemic has really highlighted where we do have these disparities. I mean, rural kids couldn't go to school in the pandemic, for instance. So I think that, this has really been highlighted. And I think that we need to start seeing access to digital infrastructure as a basic right, and financially make it accessible, and make grants and things for people who can't afford the technology, so that we get rid of this divide. Because Alex perfectly said, everybody's discovered the secret, which is this is an amazing way to do healthcare. So it's going to stay. We're going to keep doing this, but we're going to keep leaving behind a segment of our population if we don't act soon.
And Craig, over to you.
Yeah, look, I'm aware that there are sort of initiatives, mainly in the research setting, around a Canadian brain health strategy. And I think, we in Scotland are very fortunate as a very small country to be quite dynamic, to be able to produce dementia strategies, but also, like I said, on the other side of the same coin, brain health strategies. And I think it really is for policymakers and leaders to think about whether or not there should be carve out a space for a prevention and a brain health strategy. And I think it'd be great, like Alex said, to come back. I'd love to be invited back. I'd love to be face to face in Canada with you guys. But if we saw movement on brain health strategies at a national level take place across the world, then I think Canada could lead the world in this as well.
I'd like to put in a plug for CCNA's Can Thumbs Up, which is exactly that.
That's the one I'm really sorry, Megan. I was Googling it. I just could, because we've just published a paper where we cited you, by the way. So yeah, I'm sorry about that. I had a senior moment. Thumbs up. There you go.
And that's great, because we have a really informed audience, because actually Can Thumbs Up is in our discussion forum that we're just going to read the question out. So great to hear about the prevention work done across the ocean. The Can Thumbs platform at CCNA is doing similar work. From your perspective, what are the main barriers and the facilitators to implementing brain health tools within the pathways of healthcare?
Can I
Craig, maybe I'll start with you. I'm going to start with you.
So this might not surprise you, or it might surprise you, but the biggest barrier are my clinical colleagues. This is with the public. They get it. They absolutely get brain health. They get the benefits. We've done some survey work. They understand how important your brain is. There's things you can do to protect your brain, and they want to do them. They want to know more about what those things are. The biggest challenge has been trying to turn around my colleagues who work and think about Alzheimer's in a particular way. And I think that's probably where I spend most time and most effort is trying to work with people who've got maybe some legacy issues in a space about what is neurodegenerative disease. So it's in some ways it's the doctor's fault that we're not moving forward. I say that as a doctor. So.
Megan, Alex, anything to add to Craig's points? Or he summed it up nicely.
I think, yeah, I will say that one of the challenges the space we work in is psychological interventions, including sleep intervention, for instance. So we are on board as clinicians, but behavior change, particularly lifestyle behavior change, is a hard thing to do psychologically. It's a lot easier to take a pill and externalize it, but to do it is hard. So once we get everyone on board, I think we're going to challenge, which is the million-dollar question in psychology, is how to help people make lifestyle changes in behavior that are sustained.
Good point. I see nodding along with that. So we'll answer one more question, and then we'll hopefully maybe Laura will join us for the last 5 minutes. We seem to have lost her, but we'll make sure to get her thoughts on a lot of these questions. So do you see the federal government or the provincial governments as key drivers of policy and access to that fertile field of innovation development in this space? So where do you see the government role? Oh, and Laura's back to join us. Excellent.
Just in time for the right question, too.
Completely. So Laura, I don't know if you heard the question, but I'm happy to read it again if it's
I did. Of course,
Okay,
they're important, but they're not drivers. I think it's important to remember that government's job is to react, not to proact, right? So that's why I wanted to show that the Einhauser point of moving in the right direction. No, the government is not going to do this. No. And that is why advocates and clarity and voice and alignment need to happen. And I shouldn't say it's not their job. It is their job. It's their job to do the things in the far left-hand corner. And it's our job to get it there.
Excellent. That couldn't have been better timing, Laura, I'm going to tell you. But any other comments from the rest of our panelists before we close out the session?
Yeah, maybe I can just add to that quickly from the innovation space, and Laura is absolutely right. The government is not the one driving the innovation. That has to be really done jointly between the researchers and industry to move things forward. And the government really there is to help facilitate this and to really remove the policy barriers that currently exist in order to move these innovations, out into the real world and to get them into the hands of people who need them. And as Megan rightly pointed out, in an equitable and accessible way.
I should also think the government should be moving on this. I don't want to give you the sense that I don't think it's important and urgent. It absolutely is. But there's an excuse for being overwhelmed and there's a time to move. And I guess my argument is now is that time. We do actually have an opportunity, but we have not yet taken it. So after this, I'm going to go watch the throne speech with all the other policy wonks in the world. And I do not think we will see much in the way of dementia. But what I do believe is now is the time to work, because the budget cycle in Canada is ongoing and the budget is what matters, not the throne speech. So now is the time to coalesce around and ask something like 1% of the health budget, because when the health budget changes, the percentage swings with it. We can ask for more there.
Well, I think that's a really good place to end our discussion today. So I thank all of our panelists for joining us. It's been a great discussion, sharing your perspectives, your knowledge, and the projects that are underway and moving towards the importance of health system readiness. So thanks to our audience for your active participation and for joining us. I'm going to leave you with a couple final thoughts. To address the diverse challenges, we need to be bold. Bold to help solve one of the biggest public health problems of our time. And we know science alone won't be the solution. Many changes need to occur, including dementia-friendly policies, how society funds research, how governments assess the value of innovation, treatments, and for people with dementia. Much like COVID-19, a range of stakeholders are needed to slow and hopefully end the dementia crisis. No one organization or initiative can do this alone. The global COVID-19 response shows that progress is possible, but we must act urgently and collectively. Perhaps if we apply some of the lessons from COVID, we can apply them against dementia and Alzheimer's. Thank you all for your time today, and I hope you enjoy the rest of the conference.